This PowerPoint is going to take us through labor and delivery. Parturition is the process of giving birth. What initiates the birth process is not well known, but it's speculated that progesterone, estrogen, oxytocin, and prostaglandins are contributing factors to the onset of labor. There are 5 major events that occur with the birth process. These are not stages, but things that occur with the birthing process. The 5 major events are rupture of the membranes, dilation of the cervix, contraction of the uterus, separation of the placenta, shrinking of the uterus. There are 3 stages to the birth process. Stage 1 starts with the onset of the first 2 true contractions. These are usually 10 to 15 minutes apart and last about 30 to 90 seconds. At first, they may go unnoticed by the mother or may just feel like tightening of the stomach or back muscles, and then they gradually increase in strength. This stage will end with full dilation and effacement of the cervix. The latent part of this phase is when contractions become coordinated and the cervix reaches 4 centimeters in dilation. Typically, this occurs about 20 hours in a prima gravida birth. Prima gravida means a first-time birth. And active is the most rapid phase, and this is when the cervix reaches 8 to 9 centimeters dilation, and it lasts about 5 hours in a first-time mother. Deceleration, also known as transition, reaches complete dilation and presentation part of the fetus descends into the mid-pelvis. Stage 2 is the delivery of the fetus. It starts with full dilation and effacement and ends when the fetus is delivered. For a first-time pregnancy, this may last 1 to 2 hours, and someone who has had multiple pregnancies, this may last only 20 minutes. Vertex birth is when the fetus is in the head-down position and accounts for 96% of all births. This is the appropriate way for a baby to be delivered. Breech occurs in 3.5%, and shoulder accounts for 0.5%. So breech is when the feet are coming down first, and shoulder is when one shoulder is coming out first. Stage 3, once the fetus has been delivered, the uterus continues to contract. This helps the placenta tear away from the walls. The secretion of oxytocin increases uterine contractions and can be stimulated by nursing. Pressing on the mother's abdomen can also aid in the expulsion of the placenta. This stage in a first-time mother lasts about 30 to 45 minutes, and someone who has had multiple deliveries, it lasts about 4 to 5 minutes. Then in stage 4, this is the recovery period or stage, and this is where the uterus shrinks and the body returns to homeostasis. Effacement versus dilation. Effacement refers to the thickness of the cervix. As labor progresses, the cervix becomes thinner. So if a person is said to be 50% effaced, it means that the thickness of the cervix has decreased to half its normal size. Dilation, on the other hand, refers to how far the cervix is opened in preparation for delivery. A 2+ dilation means they have dilated 2 centimeters, but not quite 3. Eventually, the cervix should open to 10 centimeters. Effacement and dilation occur due to the contractions of the uterus, which pushes the amniotic fluid and fetus against the cervix. If labor and delivery proceeds without any complications, then we're going to talk about the normal birthing process and what happens to the baby. So if normal labor and delivery occurs, all of these things are going to occur. The first thing is asphyxia. This is normal asphyxia, which is caused by labor and delivery. As the baby passes through the birth canal, blood flow to the fetus is disrupted, which causes a decrease in the PaO2. These stimulate the chemoreceptors, which in turn stimulate the respiratory center in the brain to signal the muscles to perform the actions necessary for the first breath. You have to remember, as we learned in our last section, that breathing begins in utero, where the fetus is moving amniotic fluid in and out of their lungs. So the breathing process or respiratory rate is already there. Asphyxia is needed to strengthen that drive to breathe. Compression of the thorax occurs while passing through the birth canal. This does two things. First, it helps squeeze the fluid out of the lungs, and two, as it exits, the chest will recoil and expand to its original size and shape. The recoil creates a pressure change to allow air to enter the lungs. Then there's a couple other things that occur, and this is due more to your environmental changes. You have to remember the baby has been in a warm, dark, and quiet atmosphere for the past 9 months, and now it's being brought out into the cold, light, and loud atmosphere. All of this is normal, and all of this helps the first breath be taken. You have to keep in mind that the first breath has to overcome surface forces of the lung. These have been measured to be as high as -100 millimeters of mercury. That doesn't mean that if the baby isn't taking the first breath on their own, that you're going to deliver 100 centimeters of water pressure of positive pressure, because that's a different force occurring. So the baby is going to have a strong negative suck when they take that first breath, based on the asphyxia, the compression and recoil of the thorax, and then as well the environmental changes. So what things can go wrong? Well, the maternal structure can cause problems. Maybe it's too small for the fetus to pass through the birth canal, or maybe there's some other situations that can go on. The fetal presentation, the baby could be breech, shoulder, stuff like that. There could be some problems with the umbilical cord. There could be problems with the placenta, and then asphyxia, abnormal asphyxia could also occur. Dystocia is dysfunction of the uterus. It includes when it contracts too much or when it contracts not enough. Excessive contraction can lead to asphyxiation of the fetus. When the contractions are too mild, the cervix does not dilate and efface as it should, and expulsion of the fetus will not occur. Mild contractions are usually due to the use of anesthetics. Cephalopelvic disproportion is when the fetal head is either too big for the pelvis, or the pelvis is too small, or it's irregularly shaped for the fetus to pass through. Abnormal presentation is pictured to the right. Normal presentation occurs in about 96% of all births. Breech occurs in about 3.5%. Notice there is what's called frank breech. There's footling breech in the picture, and then some others include face, brow, shoulder, and sometimes the fetus can be manually manipulated to get the baby back into the vertex position for delivery. But often if they're in one of the incorrect positions, they need to do a C-section in order to deliver the baby. Problems with the umbilical cord. The worst one is probably umbilical cord prolapse. Occult prolapse is when the cord becomes compressed inside the uterus, and this is usually due to the fetus compressing the cord. Sometimes you'll see the fetus will actually grab the umbilical cord and squeeze and release, so that would be occult prolapse. Umbilical cord prolapse, generally speaking, is when the cord passes through the cervix into the birth canal and becomes compressed by the contractions. The danger of either of these situations is that blood flow to the fetus is being disrupted and stopped, and can result in abnormal asphyxia of the fetus. Fetal heart rate monitoring allows us to suspect when the cord is being compressed and allows us to intervene when necessary. Placental abnormalities. Placenta previa occurs when implantation occurs in the lower portion of the uterus. A low implant is when it occurs in the lower portion of the uterus but does not cover the opening. Partial is when it occurs in the lower portion of the uterus and covers part of the cervical opening, and total is when it covers the entire cervical opening. The problem with these is that the passage to the birth canal is obstructed by where the placenta derives. This places the mother and fetus at risk for blood loss once labor starts. As the cervix thins and effacement begins, the placenta cannot be torn, especially with a total placenta previa. Oftentimes with partial and low, as gestation continues, the origin of the placenta actually moves higher into the uterus, so the risk of bleeding decreases slightly. All forms of placenta previa previa can be diagnosed by ultrasound, so hopefully the birthing process wouldn't be allowed to continue if they had total previa, and probably not if they had low or partial. Abruptio placenta is when the placenta separates from the uterine wall before the fetus has been delivered. This is the most common cause, the most common cause of this is maternal hypertension. This includes preeclampsia hypertension, which includes protein in the urine, edema, or both. And this typically occurs about 20 weeks gestation. They don't know why preeclampsia occurs or how to prevent it. Signs and symptoms are bleeding, tenderness of the uterus, absent fetal heart tones, maternal hypovolemic shock. Abruptio placenta is the most dangerous to the fetus due to the blood loss that occurs. This leads to fetal asphyxia, anemia, and shock. Treatment for this includes having mom lay on her side, give her IV blood or crystalloid solutions to maintain her blood volume, continually monitor the mother and fetus, and preparation should be made for emergency delivery or a C-section if evidence of shock or fetal distress is present. So this all leads us up to what's called fetal demise. This is when death occurs after 20 weeks gestation or when the fetus weighs more than 350 grams. The most common cause of this is placental in origin, meaning there was something wrong with the placenta, whether it's abruptio, previa, or some other abnormality. The most common cause of which are due to modifiable risk factors is number one is maternal obesity. Advanced age, that being over age 35, can also play a role, and smoking is another contributor. Some other causes of fetal demise, causes based on the maternal side, is a prolonged pregnancy, that pregnancy lasting longer than 42 weeks, diabetes, especially if it's poorly controlled or not identified, infection, hypertension, preeclampsia, eclampsia, advanced maternal age, Rh disease, uterine rupture, or maternal trauma or death. Causes of fetal demise that are on the fetal portion are multiple gestation, so this is twins, triplets, etc., intrauterine growth restriction, congenital abnormality, genetic abnormality, infection, or hydrops fetalis. What do all causes of fetal demise have in common? Well, they start with fetal asphyxia. This is the loss of gas exchange between the fetus and mother. It increases fetal hypoxia, it increases fetal hypercarbia, and it increases fetal acidosis. If you don't remember your normal fetal blood gases, make sure you go back and review, okay? So let's talk about abnormal fetal asphyxia. So regardless of the cause, an asphyxia begins. This leads to the baby having late or variable heart decelerations, and they're occurring in response to the contractions. Next, the chemo and baroreceptors in the fetus are stimulated. This causes the fetus to increase respiratory activity, so there's going to be rapid movement of fluid in and out of the fetal lungs while it's still in utero. After this, if the hypoxia does not reverse, the fetus will take primary apnea. Now remember, this is when the baby is still in utero, so that means the baby was taking normal respirations. Then asphyxia begins, meaning they're not getting oxygen like they should, and they're not getting rid of CO2 as they should. This causes their heart rate to decelerate. The chemo and baroreceptors are stimulated, and then while in utero, they begin respiratory activity more rapidly and deeper, stronger than normal. At this point, we really want to get the baby out. However, we don't typically know this is happening. So at this point, the baby actually stops respiratory activity, and that stopping of respiratory activity is called primary apnea. If it continues, the heart rate will continue to drop. the pH will drop, the PO2 will drop, and the PaCO2 will climb. If we still have not intervened, the baby will then go into what's called secondary apnea. Beyond secondary apnea, if we have not intervened and resumed effective respirations, it will result in fetal death. Now, something that people tend to overlook when we talk about fetal asphyxia is a couple things. First of all, the baby in utero is already doing respiratory activity even though gas exchange is occurring through the placenta. So any restriction to blood flow or interruption of blood flow to the fetus is going to cause asphyxia. That is going to lead to primary apnea. We don't know when primary apnea typically is going to occur. So any baby that's delivered, and if they're not taking a first breath, we're going to assume that they have already experienced primary apnea and that they are in secondary apnea. So this is telling us to act quickly. Respirations, effective respirations, are mandatory in order for the fetal heart rate to increase. So with adults, we typically say their heart rate is needed for them to be breathing. Well, with fetus or babies, neonates, we say they have to be breathing in order to have a heart rate. So I want you to chew on that a little bit and think about it. So this is just a review of the asphyxia that occurred. So right here, we're in normal respirations, okay, right? That's what the normal ones look like. Right about here, we're going to have an asphyxiating episode of some sort, okay? This is going to make the heart rate first rise, but then it's going to drop, okay? At this point, the baby is in primary apnea. Notice the blood pressure is going to continue to rise to try and get that oxygen and blood to the fetus. After this, the fetus is going to take some weak, ineffective attempts to breathe. That's what this is. Notice how it's very irregular, okay? It's not strong breaths like these over here, okay? So this is a weak attempt to breathe, and these respirations are going to be ineffective. And notice the heart rate cannot rise back to normal because the breathing is ineffective. So then the baby goes into secondary apnea, and if we have not intervened by this point, then there's going to be fetal demise. So if a neonate is born and they're not breathing, we're always assuming they're in the secondary apnea, and meaning we want to act quickly and effectively. Possible outcomes following an asphyxiating event. Well, once fetal asphyxia occurs, it could lead to fetal death if we don't intervene in time. With some babies, this will cause all their muscles to relax, and that will include their bowels, which will relieve what's called meconium. That's the contents of their bowels. That's like fetus poop, basically. And that can be released into their amniotic fluid, and then the fetus can breathe that into their lungs as they make attempts to breathe. So meconium aspiration, or inhaling your fetal poop, is what could happen. Due to the lack of oxygen to the brain, cerebral palsy or other brain and physical deficits could occur. And there is a slight possibility that the baby could be delivered with full recovery and no defects or deficits whatsoever. So when we're dealing with neonates and deliveries and we're called and said a mom's going to deliver, our job is to prepare for resuscitation. We're going to go check the admit room and check for the presence and function of all of the necessary equipment, and you want to do this on every shift. You want to anticipate if it's a high-risk delivery, meaning you want to know the maternal history, pregnancy history, and if there's any factors that make it a high-risk delivery. You also want to do continuous monitoring of the mother and fetus during the labor and delivery. Lastly, you want to have some trained personnel in-house. This must be someone in the hospital who is capable of performing intubation on neonates. Now, depending on where you work, Some hospitals, especially up further on the east and west coasts, respiratory therapists are responsible for all of this, and they are the leader of the resuscitation of a neonate. In the Midwest, you see more nursing being the leader of the process and respiratory therapists there to assist. So depending on where you're going to be, depends on your role and responsibilities. So here I have a couple examples, and the question posed is, what can be anticipated as a high-risk delivery? For this one right here, we're going to say she's 11 years old. Okay, so if she's 11 years old, what is the risk? Boop. That's what. This lady here is incarcerated, actually due to drug use while pregnant. In Tennessee, if a baby is born with a drug addiction, the mom actually goes straight to jail. So just a FYI on that one. And then here we have the multi-gestations. So with each of these cases, these would be high-risk situations. This concludes this PowerPoint.